to all to having me today for this lovely conference and for amazing people and amazing presentation. Let me introduce to myself. I'm Dr. Yousef Nasrawi. I've earned my bachelor degree in Jordan University of Science and Technology in 2015. And then I took the MFD and MFDS from the Royal College of Surgeons of Ireland and Glasgow. And I have obtained also the American Dental Board and the Master in Clinical Orthodontics from the same university. And I'm currently a lecturer in the same university also. So today, our subjects will be specifically about orthodontics and how we deal with the deep bite patients that have a curve of SPE, accentuated curve of SPE. So the subject will be about curve of SPE, speed of leveling using different orthodontic arch wire, size and material. It was in a randomized clinical trial. Okay. So according to the Andrews, in the 1972, curve of SPE in a good occlusion ranged from flat to mild, and the best intercuspation happened when the occlusal plane was relatively flat. And different ways on how to measure the curve of SPE according to different authors adopted a two-dimensional approach by measuring directly from the dental cast or by using the three-dimensional way by digitized images. And several ways was used to manage the deep overbite have been suggested. By all of them was aimed on the upper or lower incisor intrusion or upper or lower posterior teeth extrusion, and with the association with the lower incisor proclamation, of course, if you haven't deleted the torque in the arch wire. It has begun with the continuous arch wire in all mandibular teeth with a reverse curve of SPE, which most of the leveling occurred by extrusion of posterior teeth and for a lesser degree by intrusion of the anterior teeth. So technically it was in 60% by the extrusion of posterior teeth, and it was associated with the intrusion and the proclination of the anterior teeth according to different authors in several years. Our aims and scientific of this study is to evaluate the efficiency of different arch wire sizes, which I will talk about now. It's 1725 stainless steel, 1925-inch stainless steel, and the 2125-inch TMA arch wire, which is called titanium molybdenum arch wire, in aim to correct the excessive curve of SPE in the mandibular arch. Also, the specific aim was to record the time needed to level the excessive curve of SPE using the above arch wires. To our knowledge, this study was the first to compare between different rectangular arch wire sizes and material to level excessive curve of SPE in the mandibular arch. The previous studies and the latest study was in 1992 by Al-Qabandi. He used to manage the differences between the rectangular and the round arch wire, but my study was the first to differentiate between the rectangular arch wire. And I'm happy to announce by this conference that my study was accepted and published in the investigation oral journals by 2 days ago, and after working 2 years on it. So it's quite happy news for me. Now let's move to the material and methods. This study was reviewed and approved by the IRB Institutional Review Board Committee at Jordan University of Science and Technology. And this study was a randomized clinical trial with a 1-to-1 allocation ratio. It was conducted by our clinic, postgraduate orthodontic clinic, and the total sample size was comprised of 51 patients. The inclusion criteria, it was a little bit tall. It's a range between the age of 16 and 30 years. Overbite covering more than half of the lower incisor height. It need to be a deep overbite patient also. Curve of SPE more than 4 millimeter, which is equal to be an accentuated curve of SPE. I will showing the picture after that, after this slides, explaining how it need to be accentuated in my study. Mild crowding in lower arch were non-extraction treatment. Why non-extraction treatment? Because in orthodontics, and it's an old philosophy that if you have a patient with a deep bite and if you extract in the lower arch, you will deepen the bite more. And recently, there's another study called that the deep bite patient, it's all inclusive about the growth and the genetic, how you transmit the deep bite by the genetic and the growth. And the extraction is not prohibited 100% in deep bite patients. If there was a severe crowding, or if the tooth was out of the arch, you need to extract this tooth to align and level the whole arch. All permanent teeth also are present except for the third molars. A good oral hygiene and healthy periodontium. Normally inclined or retroclined lower incisor need to be done also in the patient with an average or reduced lower vertical height. Why? Because while you are putting a reverse curve of spee in the wire, you are aligning the curve of spee by extrusion the posterior teeth, and while you are extruding the posterior teeth, you will open the bite more and the vertical height will be more. So that's why it needs to be averaged or reduced lower vertical height. After recruiting the patients who met the inclusion criteria, the intervention was randomly allocated using a permuted random block size of 3. All patients receive 0.022-28-inch slot American orthodontics rough prescription brackets, and subjects were allocated into 3 groups. Group 1, which was for the 1725 stainless steel for the 14 patients, and Group 2, 1925 stainless steel 15 patients, and Group 3, 2125 TMA 14 patients also. And the average group, you can see the average age is between 20 to 22 years. A dropout was considered if the patient failed to attend the regular monthly appointment, or if the bracket or the molar tube was debonded during treatment but failed to be rebonded back in a place within 24 hours. So, to include the 6s and 7s need to be included to align the curve of spee. If the 7 tube or the bracket on the second molar was debonded, and more than 24 hours, the patients contact me to include it again in the wire, it need to be dropped out because some variability had happened to the curve of spee, and the second molar may be inclined or angulated a little bit. So it's difficult to put a stainless steel wire into a inclined molar. Glass ionomer posterior bitoblock were added on the upper molar to allow lower arch bond up and to remove any interferences from occlusal contact. So, we called it as a bitoblock. I put it in the upper molar, not the lower molar. Why? Because if I put the bitoblock on the lower molar, I may aid in intrusion of the first molar or the second molar. So to prevent this happening, I put it on the palatal cusp of the upper molar. It will aid in to raise a bite a little bit without interference with the first and the second molar in the lower arch. And the wire sequence was, for all group subjects, teeth alignment started with around 14 niti arch wire, then a sequence of 16 niti, 18 niti, 16, 22 niti, were inserted before inserting 1622 stainless steel arch wire. Before the insertion of the leveling arch wire in the 3 studied group, lateral cephalogram, which is the T01, before the treatment I took it, and periapical radiograph for the lower anterior teeth were taken also. Many of you may ask me why I took the periapical radiograph, because this study was contained 3 papers, and from this study we've conducted the 3 papers else than the curve of spee. We've conducted the pain score level. We have conducted also the root resorption of the lower anterior teeth in association with leveling curve of spee, and the speed of treatment, which what I presented today for you. And also we're taking all of these variables were taken for the periapical radiograph, alginate impression, and lateral cephalogram. Alginate impression for the lower arch were taken, and utility wax was used to cover the lower arch bracket, not to distort the impression upon removal from the mouth. Cast, then poured in the laboratory using dental gypsum type 2. These steps were done monthly following the insertion of 5 mm reverse curve of spee until a flat curve of spee has been achieved. So I've spoke about before about the curve of spee. It needs to be more than 4, and the lower limit for us, it was 5 mm to be accentuated in A to have some differences in the results. The patients were followed up on a monthly, and on each monthly visit, impression was taken for the lower arch. So we have took T1 to T5. Outcome was measured. The curve of speed depth changes during leveling was taken from the dental cast, and the lower study model was used to measure the depth curve of speed due on the surveyor. And due to the COVID-19, unfortunately, the final record T5 was taken with a 3-month gap from T4. And all dental casts were trimmed and mounted equally on dental surveyor to ensure an accurate result. As you can see in the picture, the digital caliper was mounted on the surveyor to measure the specific amount and exact amount of the curve of spee or the depth of the curve of spee itself. Duration and the time needed also was measured. It was measured by in month interval from the insertion of the RCOS until the curve of spee of 1 millimeter or less was achieved, which will be the T5. Here's what this is the picture, not from my research, it's from Google. I've shown to you to explain how it could be accentuated. You can see the curveness of the lower arch from the lower molar to the lower incisor, and you can see the second and the first premolar were not in a fully occlusion. So the aim to align the curve of spee is to extrude the premolars to have an correct overbite. And this is also the reverse curve of spee arch wire, how it need to be made. And there will be a different torque level will be added during fabricating the reverse curve of spee without So once you are fabricating the reverse curve of spee arch wire, you are adding the torque in the posterior and the anterior teeth. And if you want to remove the torque, you need to make have a specific plier. It's called turret plier, and need to be inserted in it to have a zero torque for the wire. For the result, the overall curve of spee leveling was on average reduced by 3.5 millimeter for group 1, 4.8 millimeter for group 2, and 4 millimeter in group 3. The differences in overall changes was significant between group 1 and 2 and between group 2 and 3. There is no significant differences was detected between group 1 and 3. A duration of excessive curve of spee leveling was on average 6 months for group 1, 5.7 for group 2, and 6.2 months for group 3. Significant differences were detected between group 1 and 2 and between group 1 and 3, and there is no significant difference was in group 2 and 3. So as shown here in the table, you can see the treatment duration of curve of spee. The mean time that I spoke about before is the fastest one was 1925, which is the group 2, and here is the significant difference between the mean. A significant difference of a 3 studied group and the standard error and the mean differences for the curve of spee with the confidence interval was measured and the p-value. You can see the differences between group 1 and 2 and group 2 and 3, and there is no significant difference in group 1 and 3. So for the discussion, these findings were in agreement with the Fisher-Brandes et al. In 2000, who stated that a relatively large torque play occurs in a small arch wire dimension, explain less force applied to the teeth by a bracket slot. How it could be done? So if I have an 1725 stainless steel, which is fitted in a bracket slot 22 to 28 inch, there is differences in the sizes. So there will be a play between the wire and the bracket, and there will be a less force applied to the teeth by bracket slot. So that's why group 1 have more months to be have leveled curve of spee. This should be also associated with a high amount of strength and low friction with the group 2 arch wire, which is 1925. So 1925 stainless steel material, it has a high amount of strength, low friction. And the 2125 TMA, which is a group 3, it has a high amount of strength and high friction. So that's why group 2 and group 3 was relatively close to each other by the month value, but the fastest was for the 1925 stainless steel. So as a conclusion, 1925 stainless steel arch wire was the most efficient in leveling curve of spee with the less time. The strength of this study, it was a randomized clinical trial, and it was the first study to investigate different rectangular archway efficiency in leveling curve of SPE. Limitation of the study, it is a high, sorry for the error in the writing, it's a high female-male ratio. So the female number was more than the male ratio. And due to the COVID-19, a gap of 3 months was placed without follow up the patients in all group, which could affect the duration of time to level curve of SPE. As I mentioned before, there was a gap of 3 months due to the COVID-19. Further recommended research about curve of SPE, a clinical study comparing the ceramic bracket with the metallic one, which the whole sample size for me, it was a metallic bracket, in order to measure the speed of leveling curve of SPE. A clinical study using the same archway in this study, but with removing torque anteriorly, which was added while fabricating reverse curve of SPE. As I mentioned before, that while you are fabricating reverse curve of SPE in the wire by looping it toward the lower incisor, you are adding torque anteriorly and adding buccal torque to the posterior teeth. So I wish I could in a future study, by removing the torque, how could affect on the anterior teeth and how could affect on the buccal torque for the posterior teeth. So that's all. And thank you so much. It was a pleasure for me.